Great. So hi, everyone. Thanks for coming today. So as the coordinator of the VADF Speaker Series at the University of Alberta, that stands for Visual Art and Design Forum, I'm pleased to welcome you to a webinar called Co-Design Beyond Pandemics, Transparency and Design. The presentations that you'll hear today are featured in an international research project called Recovery and Renewal of Participation in Healthcare Change. This project aims to build capacity and resilience in co-design in health. The project team has been exploring how co-design practices evolved to engage the most impacted communities in health service research, delivery, and improvement during and beyond a pandemic. The projects you'll hear about today are related to transparency in the design process, and as well include co-design. So this is the third talk in the Visual Art and Design Forum Fall 2023 Speaker Series, and it's also the third webinar in the Co-Design Beyond Pandemics webinar series. Our next one is going to be October 26th, hosted by the Health Design Studio at OCAD. At this time, I'd like to acknowledge the Indigenous peoples of all the lands that we are on today. I'm at the University of Alberta in Edmonton, Alberta, Canada, where its buildings, labs, and research stations are located on the traditional territory of Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, and Ojibwe, Saulteaux, and Anishinaabe nations. While we meet today in our virtual platform, we can take a moment to acknowledge the importance of the lands, which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous people and their cultures. Today we have 4 speakers. I'm going to introduce everybody, and then we'll have the speakers speak, and then what we'll do is have questions at the end. So if you have questions while the speakers are speaking, please feel free to put them in the chat. Dr. Katie Dainty is a qualitative social scientist and research chair in patient-centered outcomes at North York General Hospital. She has expertise in the areas of patient and family experience, implementation science, patient-centered outcome measures, and quality improvement in healthcare. Her core program of research focuses on using qualitative and co-design methods to unpack long-held assumptions about bystander experience and survivorship following sudden cardiac arrest. Katie and Damien will be presenting together in the first talk. Damien Henderson-Leroy is a master's student in the Health Science Systems Research Program at the University of Toronto's Institute of Health Policy, Management and Evaluation. His research interests include patient and family engagement, health research, services and innovation, co-creation, quality improvement, and knowledge translation. Most recently, he's been working under the supervision of Dr. Dainty, leveraging qualitative methods to explore the survivorship experiences of both sudden cardiac arrest survivors and their relatives to inform collaborative design. Dr. Joe Langley is a design engineer and academic at Lab for Living in Sheffield Hallam University. His work focuses on the application of design practices for research, design, and innovation in the field of health and well-being. In his early work, he became interested in 2 interrelated things: projects that produced great outputs but failed to make it into practice, and the value of co-design and co-production to address this. He's been exploring the intersection of these 3 things ever since. And our 4th speaker, Nadia Bizawi. Nadia Bizawi is a designer, researcher, and educator working in the spaces of health and community engagement. Nadia is the manager of the Health Design Lab at Emily Carr University and an instructor in the Faculty of Design and Dynamic Media. Through her role at the Health Design Lab, Nadia leads design research and social innovation projects related to Indigenous health, aging, substance use, and complex care. So those are our speakers. After the speakers present, there will be a time for discussion about creativity and making, as well as transparency in the co-design process. If you have a question, please put it in the chat and we'll come back to you after the speakers have presented. Excuse me. Project partners, I should mention briefly, this project is an international collaboration between the Health Design Studio at OCAD University, the Design Health Research Innovation Lab at the University of Alberta, the Health Design Lab at Emily Carr, the SE Research Center at St. Elizabeth Health, and Lab for Living at Sheffield Hallam University in the UK. Oh, and I forgot one, the CoLab for Community and Behavioral Health Policy at the University of Washington. Okay. So our first speakers, I'd like to welcome and introduce Katie and Damien.
Terrific. Thank you so much, Jillian. We're really glad to be here. This is a really exciting opportunity to talk about co-design with a community that is interested in that and interested in furthering the practices around co-design. So really, really happy to be here. Today, we're actually going to present a project that was Damien's master's thesis, and I'm happy to report, which I'm sure he will too, that he has successfully defended his thesis very recently. So he can be put those letters at the end of his name now, which is fantastic. But what it is really using the co-design process to develop a mobile app intervention for cardiac arrest survivors. And we'll tell you a little bit about the reasoning and rationale for that project, and how co-design has been absolutely instrumental in developing that intervention. Next slide. So essentially, I've been working in cardiac arrest for about 15 years, and for a very long time, we actually didn't have very many survivors. Sudden cardiac arrest only has about a 10% survival rate, but it has been climbing, and it is between actually 10 and 30% in some parts of the world. And so therefore we have more survivors, and that means we have to pay more attention to survivorship and what happens to them after they leave acute care. And that's actually been quite a gap in research and knowledge in the last decade or so. And so as we start talking, I've spent quite a bit of my time doing research, qualitative research with survivors and their family members to try and understand what that survivorship journey looks like. And that's sort of represented by the diagram on the left, the agency diagram on the left. And we've learned a lot. We've learned a lot by listening to survivors and family members about their experience, their perspective, their experience of the healthcare system, their experience of the event itself, etc. But we haven't really been able to move to that next level. So how do we use those experiences to actually move into an intervention that's going to help them have a better survivorship and a better, a more patient and family-centered outcome from this life-changing event? So what came to mind, certainly with the advent of COVID and the healthcare system, being quite overloaded, we decided that a mobile app would be a great modality to be able to help many survivors in many locations in many health systems, regardless of location or system resources. But in order to do that, we really needed to dig down and listen to their experience, not just from an experiential standpoint, but also from a needs standpoint, and how we could convert those needs into intervention constructs. And so that's really where the experience-based co-design framework came in so helpful, and why we found that co-design was the only way to go to develop something that was actually going to be used and fulfill the needs of the survivors and their families. Next slide. So we had lots of partners on this project, certainly the survivors and close family members themselves, as well as the clinicians and healthcare providers throughout the system that help, that care for these survivors, as well as a few organizations that are both pan-Canadian as well as here in Toronto. The Canadian Resuscitation Outcomes Consortium, North York General Hospital, where Damien and I work, the Center for Digital Therapeutics, which is a terrific center at the University Health Network here in Toronto that is focused entirely on patient-centered digital therapeutics. And of course, the University of Toronto Engineering Department, who we've been working very closely with in terms of the design of the platform, taking into account the outcomes of the design work that Damien's going to present today. Next slide. So just a little bit of background on the work that underpinned this. So myself and a great team of people did, as I said, qualitative work looking to understand the needs of or the experiences of survivors and their families. And that actually led to us doing a sort of first level co-design project, which was a James Lind Alliance priority setting partnership. And for those of you that don't know what the James Lind Alliance is, I'll encourage you to go look at the website. But they are a group of people that began in the UK and developed a methodology, a very specific methodology for research priority setting that is very much forefronts patients and families in many conditions and many healthcare areas. I think they have well over 200 priority setting partnerships now in various areas of the healthcare system. But it very much is about a co-design of that priority list. And then the ultimate goal is to end up with a top 10 list that reflects not only care providers, but also patients and families in equal weight. So that was a very powerful and exciting project where we really learned that the post-acute care setting was where patients and survivors and families needed the most support. So that was really a really great piece of work. The second piece of work was done by a group out in Alberta, my colleague, Dr. Matt Duma, and his colleagues, who really dug down into the needs of families and sometimes what we refer to as co-survivors of cardiac arrest. So when a loved one has a cardiac arrest, there is a lot that happens both at the time of the arrest as well as afterwards, and really understanding that families are also survivors of this life-changing event. And so what are their specific needs? And a lot of qualitative work has been done in that area. And so his team developed, did a very extensive scoping review to look at that literature, both qualitative and quantitative, to really, and it was super helpful for us to be able to pull on some of that existing knowledge leading into our co-design process. And so, so we use both of those things to develop the intervention development project that we're going to present today. And this involved conducting focus groups with those stakeholder groups and with lived experience of sudden cardiac arrest, about their recovery and their survivorship and what they needed to feel supported in that space, to analyze that focus group data, not just from an experiential standpoint, but with a view to informing intervention development, and then to really generate those considerations that will go into the next stage of the co-design process, which is really building those considerations into the platform itself. So from there, I will hand it over to Damien, who will tell you about all the gushy details.
Yes, thank you, Katie. Next slide, please. So on the right, we have the adapted co-design process that we used. It starts with setting up the project. So that involved reviewing the literature, seeing those gaps identified by the work done that underpins this project. And then we move towards engaging individuals with lived experience. And here you'll see steps 2 and 3 are both engagement steps, because the first one is engaging survivors and their family members. The next one is engaging clinicians and researchers. While we were doing these steps, well, what I'll speak on specifically today is step number 2. But while you're doing steps 2 and 3, you're always thinking about step 4, which is the joint co-design workshop, where you bring people together, you share the experiences that you've collected, and you figure out how to move forward and how to design an intervention that meets the needs identified. So we took an experience-based co-design approach since we wanted to develop a supportive recovery intervention informed by lived experience and designed to support sudden cardiac arrest survivors and families into the long term. And experience-based co-design is known for prioritizing lived experiences in the design process. Next slide, please. So we had to adapt our engagement approach to fit the virtual environment. The use of video conference platforms for focus groups allowed us to continue a pan-Canadian approach to recruitment and engagement. Pivoting to virtual platforms for participant engagement, we leveraged relationships with professional networks and organizations, such as CanRock and the Heart and Stroke Foundation of Canada. We also leveraged social media platforms to recruit participants for the study by posting advertisements for focus groups in closed groups on social media. We encouraged potential participants to invite others who they knew met the criteria, as well as their close relatives, to enhance our recruitment. Having collected and analyzed the perspectives of individual lived experience at this point in time, our team is now considering methods of engaging survivors and family members in the design of an intervention prototype, which is our step 4. Next slide, please. So our experience, we first approached it by recruiting participants, right? We leveraged our professional networks to do so. In the qualitative realm, we call this purposive and snowball sampling. We then held 2 sets of focus groups. The first set was for survivors and the second set was for family members. Now, some of the work prior to this project involved dyads, but in this case, we decided to hold separate focus groups to reduce the risk of participants possibly changing what they would otherwise share with us out of concern for their loved one who may be present at the time. Literature showed that survivors didn't always feel comfortable sharing everything with their family members and vice versa. So we wanted to hold these separate sets of focus groups to minimize that risk. The video conference platform made it very convenient for us to engage individuals from across Canada, and it made it convenient for our team. It's a little easier to organize an online focus group than to have an in-person focus group, especially in the context of the COVID-19 pandemic when restrictions were in place. Qualitative research methods informed our approach to the focus group, so how we designed the question guide and the strategies for moderating those focus groups. And doing this at this point in the project helped to build rapport and involve community members early in our co-design process. Next slide, please. So here we have our key outcomes. On the left, we have the themes identified from the perspectives shared by individuals with lived experience. And on the right, we have the key considerations for the intervention under development. So theme 1 on the right relates to participants' perspectives trying to navigate their lives after the cardiac arrest in terms of physical and emotional challenges, while trying to integrate back into their regular daily lives with little direction and lacking information. The sub-themes below included setting expectations for the recovery process, understanding changed bodies or new bodies. They may sometimes have medical devices implanted or new medications after discharge from the hospital. Understanding the unanticipated impacts, as well as additional challenges specific to family members and wanting to connect with peers who have similar experiences. Theme 2 refers to the participants' descriptions of the dynamic nature of their recovery, their concerns, and their needs over the course of those first 12 months after leaving the hospital. And the 2 key sub-themes here were nonlinear healing process and turning points. So nonlinear healing process referred to that irregular and oscillatory progression through that long-term healing process. While physical recovery was described as somewhat more straightforward in how it progressed, other aspects of recovery, such as emotional recovery, were described as progressing in more of an ebb and flow, sometimes moving 2 steps forward and 1 step back. Turning points referred to those points along the 12-month journey where participants recalled experiencing a shift in their concerns or needs. So for example, a focus towards recovery, prevention, and prognosis, as opposed to the very early stages after the hospital, where key concerns include recurrence or short-term complications from any treatments they had received in hospital. So from these themes, we developed key considerations for the intervention under development. And those were to aim to provide or facilitate the following in order to support sudden cardiac arrest survivorship. And that included information and the setting of expectations for the recovery process, collecting and visualizing recovery data to help survivors better understand their outcomes over time, offering tailored adaptive programs that change with the end user's needs over time, in particular, being mindful of those turning points that they had identified, and facilitating peer connection and social support. So with these considerations identified, as I had mentioned, our team is now thinking towards step 4, the joint co-design workshop, where we will bring everyone together and try to design components for the intervention that we are trying to develop. Thank you for your time.
All right. Thanks, Katie and Damien. Great work. And here's some contact information if you have questions on the project. Now I'd like to introduce Dr. Joe Langley, our second speaker. Welcome, Joe.
Thanks, Gillian. So I'm going to try to talk as quickly as possible about a project that has been called Learn Together. It was funded by the NIHR. Can we click on to the next slide, please, Gillian? So Learn Together is about serious incidents of harm that occur within the NHS and the subsequent investigation processes that occur afterwards. So there are an estimated 10,000 serious events within the NHS each year. There are more than that in terms of incidents, but then 10,000 of them are classified as serious enough to warrant the subsequent investigation. Organizational learning is a key stated aim in the policy documents of individual hospitals. But the research that we did found that the conduct, approach, and impact of investigations is hugely variable. And there's an ever increasing cost of litigations. What was interesting is that the reasons why people pursued claims are really complex, but simply getting answers is a really key one. So there's often this perception that the investigations are not transparent and there is missing information. There's something that doesn't feel right about the responses and conclusions that are reached. So patients and families are not routinely involved in the investigations up to this point. And we also believe that not including them in this investigation means that the organizations are missing a key perspective in understanding what happened and therefore in the learning that they can take from the investigation. So the questions we were asking were, what if we can better involve patients and families? Can we improve learning? And what impact might this have on claims and on the patients and families' sense of justice and healing? So if we can move on to the next slide, please. So this was a very large collaboration. There was multiple universities. Those listed are the sort of primary ones. There was University of Birmingham, lots of others as well. And the grey boxes on the right loosely describe the sort of project structure. The proposal was written with patients and families and staff that are investigators and staff that have been investigated. And that is a model that was in every aspect of the project. So in the project steering group as co-applicants on the funding, the advisory group, the project management team, and then throughout all parts of the process. Sorry about that background noise. That was my son just grabbing something from that. So in the research, co-design, testing, and then this last section, I haven't worked out whether it's re-co-design or co-redesign. There was patients, families, investigators and staff that have been investigated in every single step all along the way. So if we can go on to the next slide, please. The project objectives were to develop a new investigation process that involved patients and families, to apply a restorative learning frame to this new process, to develop relevant supporting resources for the different stakeholder groups, and to consider and respond to potential context-specific variations. So does this investigation process and the support, the resources to do it or conduct it vary in any way between acute mental health or maternity settings or contexts? Can we move on to the next slide, please? So the plan and proposal for this piece of work was submitted before COVID. And then the research phase was conducted. And during that time is when COVID happened. So the research phase was able to continue. They switched to doing some of the research activities online and interviews. The research was comprised of doing a documentary analysis of all of the policy statements for 50% of the trusts in England, interviewing 60 partners who were a mixture of patients and families, staff who were investigators and staff that have been investigated, and NHS England policymakers for patient safety, and then doing a literature review. So there was 3 sources of sort of evidence that came from the research phase. And so they were able to largely continue doing that in the constraints of COVID. But we had to rethink the co-design process because this had been planned as a series of face-to-face interactions. So we moved to a multiple channel process where we used the Miro board. You can see a screenshot of one of the Miro boards we used throughout as an ongoing. It wasn't just something that was accessed and shared at events. It was something that our partners, co-design partners, there were 60 of them, could access at any time from the start of the co-design process right the way through and can still access it. So this was a living, live, ongoing document. We also included postal channels. So we were posting information and activities to people at their homes or their places of work. And we were hosting online events, and there was email communication amongst all of that as well. The online events were largely through Zoom, but we were using various different platforms on that, sharing the Miro board within those activities and those online group interactions, but also using Jamboards and various other digital tools. When we started planning this process, the context of this particular topic of serious incident investigations is what we would define as quite a sensitive topic. There are families who have lost loved ones and been through investigation processes that have compounded the harm and trauma that they've experienced. They've had very poor investigation processes that have been anything but transparent and given the impression of trying to hide information and outcomes. So there were some quite adversarial perspectives and views. The same could be said for staff that had been investigated. There were staff there who had felt incredibly let down by the system, the organisation, their professional bodies when they were being investigated for having caused some kind of incident. And whether the outcome placed any responsibility with them or not, the ways in which they were treated through that investigation processes left them with a huge legacy of trauma and compounded harm on harm. So we had some very different perspectives, very entrenched views, people who had been on repeated political campaigns to have their particular case reinvestigated, even taking it up to the health secretary within the UK government. That's just, I'm putting that as a perspective of context of the sort of across the 60 people we were inviting into this co-design process. There were some very, very different and quite polarized and entrenched positions. So before we brought everyone together for the co-design, we wanted to give them an appreciation of the research evidence that we had found from the interviews, the literature review and the policy document analysis. And we wanted to try and give them an appreciation and understanding of the various different perspectives, not saying that one's right or wrong, but just that there are different perspectives. And at the same events could be, in a sociological sort of narrative context, could be experienced in very different ways. There are multiple truths to these incidents. And this meant that that very first interactions, which are highlighted here as Welcome Pack and Rebuilding Investigations Kit, were posted to people as individual activities. We're not asking them to send something back to us or send information back. It's for them so that they could come to this understanding before coming to meet everyone face to face. And this became a really pivotal moment. Gillian, if you could move on to the next slide. So we took the evidence from all of the research and we developed it into a series of narratives about incidents and subsequent investigations. And we went through a process of converting this into a sociological narrative that was interactive. So the person engaging with this narrative would take on the role of one of the characters and be forced into a position where they would have to make decisions about what happened, what evidence they accessed, and what interpretation they applied to that evidence. They were essentially adopting the role of the investigator. And we invited them to lay out the narrative from the different perspectives of the different actors. You can see on the left-hand side, this image, the different actors within this narrative are laid out, and the person engaging with this activity would lay out the relevant parts of that according to that person's perspective. How they defined themselves as an investigator and how they defined their investigation processes changed what they found out. And this absolutely represented everything that we found in the research. This was a manifestation of the evidence, an embodiment of the evidence. But in giving it to people in this way, rather than a didactic, this is what the evidence found, bullet point, bullet point, bullet point, this was a sense-making process. We were inviting them to make sense of that evidence for themselves. So it becomes knowledge within them rather than just trying to punch it in with a series of bullet points or text points. The feedback we had from this, and I'll come on to that in a second. Gillian, could you move on to the next slide, please? So our experience within this context was that we had the situation within COVID. We had multiple co-design projects running at the time when COVID hit. And for many of them, we had to pause. It wasn't just an automatic jumping onto online forums. We had to reformulate what we were doing and how. And so it compressed our time frame and created a backlog within a multitude of various different projects. But it also gave us the opportunity in some projects, especially this one being one of them, where our partners were giving us freedom to explore different ways of engaging with our co-design partners. And the activity that you saw just then, that moment that we sent to people when they invested an hour's worth of their time, gave each person within our co-design group a common yet completely unique individual experience of immersion in that holistic representation of the evidence, but it also built this empathy for those different perspectives. At the same time, it put them in this creative and optimistic mindset, because one of the fantastic things about that interactive narrative was that they could begin to speculate about how they could change the narrative. It gave them the agency to see, how could I do things differently? How could I change this? So it put them into that mindset of looking to make improvements, looking to change things. Gillian, could you move on to the next slide, please? So this project, we're just writing it up, and it started in just before COVID. It's already had impact. So it's been built into NHS England's new policy framework. It's been delivered within five hospitals in the north. We accompanied it with an ethnographic evaluation, and then we made redesigns. It's been downloaded by several hundreds of people across the country, in investigators in various different trusts. And we've had some wonderful feedback from our co-design community. So examples of this include on sort of a couple of quotes on the left there. This was from a family member where they came to that appreciation and understanding of the term second victim, which is sometimes applied to staff. And before now, their perception of that term was that it was slightly disrespectful to the families, the victims and the patients. in that their staff were having this victim identity applied to them as well. Another set of feedback, this is from someone who's currently co-authoring the chapter with me when we're writing this up. She said it was an entirely non-threatening way of enabling her to see and appreciate other perspectives before she met those people. And it set the whole tone of the project that made that person hopeful from the very outset, before they'd even met. Could we move on to the next slide, please? Okay, if we could just go back, there's one point I'd like to make before get on to the question there, Gillian. So one of the things which was completely unintended about this and was a really interesting and fascinating sort of outcome was that once people had done this activity, this interactive story activity, which made them appreciate the evidence and different perspectives before we entered the co-design process, they started tweeting about that experience using the hashtags and the Twitter handle. And other people who had received the same kit and done it and had the same access to the same social media handles got on Twitter and responded. And this narrative, this dialogue, this iterative dialogue that is essential to co-design started before we even met. They began that process of building those relationships and relating to each other about this topic before ever we had actually got into a Zoom room and started talking about it directly. And I think that was one of the, as I say, completely unanticipated, but really inspiring outcomes that came from that particular activity. But I think what it showed for us was the importance of, it's not just about the dialogue you have in an online platform or in a face-to-face meeting. These things we can stretch out in various different ways through various different channels and give people that space and time to start dialogue in old-fashioned ways. It's like almost the post. It's a kind of old-fashioned exchange of information that takes more time, but that time actually allows perhaps more reflection, allows people to formulate thoughts and not being asked to give their responses there and then in the moment in that face-to-face interaction. They've got time to formulate consider their responses and then bring that to a face-to-face dialogue in some way, shape or form. And this was one of the innovations from the experience of COVID, the early experience of COVID, which really stayed with us as a learning and a reflection of how perhaps we hadn't been doing co-design the best we could have done before COVID. So my questions, Gillian, on this, I just had to, I was thinking about how this relates to transparency. And I think there's some very obvious things like the Miro board about how it enabled everyone to see and engage with the co-design process at all times, day or night, whenever. But I think there's what I might classify that as sort of procedural transparency. But I think there's something around the transparency of meaning. So it's this kind of getting to the heart of the intent of what people mean and their views and perspectives. When people say things, it's not always necessarily true that others understand our words in the same way that we intend them. And so having that sort of iterative dialogue and different forms of communication and interaction actually enable us to explore these things in different ways and try to get more into the heart of what people mean and those different perspectives. That's all from me, I think, Gillian.
Thanks, Joe. That was really great. And nice that you included a little bit of information about how you thought this related to transparency. So thanks for that. All right. So our last speaker is Nadia. And so Nadia is in Vancouver and at the Health Design Lab. And so welcome, Nadia.
Thanks, everyone. So we'll just start off with the next slide here. So hi, as Julian mentioned, I'm from the Emily Carr University, which is situated on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And we'll get into a little bit more about the project that this was done over Zoom. So it actually had a little bit more reach in terms of the territories and lands in which we engage with in terms of our participants. So next slide. Great. So every year in BC, thousands of people experience stroke and a brain injury or spinal cord injury, adding to kind of many thousands more already living with these conditions. And all three of those conditions are lifelong and have direct impact on the functioning of the brain and the central nervous system. So with some people regaining some of that functioning as well, but other kind of, trying to engage with the rehab and recovery system within BC, which currently is a little bit disconnected, which is why this project is called Gathering Perspective, which is looking at how can we engage people who've experienced a stroke, a spinal cord injury, and a brain injury as part of that process towards looking at how can we look at policy change. But policy change is many, many years away. So it's looking at how do we even start that approach, knowing that there's been different strategy documents developed over different decades or different periods of times by different organizations within BC, and different to what Joe, coming from the UK, where there's a National Health Service in BC, and in Canada, there's kind of regional. So the province of British Columbia has its own kind of Ministry of Health and separated into different regions. So that's kind of part of what's contributing to a little bit of that disconnection. So this project is looking at specifically in rehab and recovery, how can we bring those systems and services together to really support the people and the needs that they have today. And so next slide. So the goal really of this project has been to, how can we create a client-centered, systematic and province-wide approach to rehab and recovery. And that's been done through a partnership that's led by the Heart and Stroke Foundation, who received a systems change grant from the Vancouver Foundation, and really brought the Health Design Lab on as partners to support with the community engagement. And so there was our team, the Heart and Stroke team, leading a steering committee, which also included Spinal Cord Injury BC, After Stroke BC, Brain Injury, Brain Wellness Program, and BC Brain Injury Association. So that group actually met, I want to say, every 2 to 4 weeks online. And we ended up doing all of our engagement online, which we'll talk through that. And interestingly enough, we never actually met in person until I think after phase 1 of the project. So this was our first time kind of figuring out, January with 2022, even last year, thinking about this population and engaging in person wasn't really going to fit for this project. So it was looking at, how can we take this online and actually think of that potentially as a benefit and pivot from some of our previous ways of really focusing on making in person and kind of, trialing a new thing. So this was new for us in the Health Design Lab at the time. Great. So next slide. And so for the timeline of the project, as you can see here, there were many, many different phases, but we started off in January 2022. So and ended around this summer. So about 1.5 years for this project. And there were kind of 2 key phases. So the first one was looking at community engagement, which engaged 3 injury groups that we had. So spinal cord injury, brain injury, and stroke. And so people who themselves have experienced that, and as well as some care partners, as well as researchers and professionals working in that space. So we'll dive into how we did that a little bit later. But then the second phase looked at how do we take some of that knowledge, amplify that, reach back out to the community and see if what we heard actually resonated with them, or if we could gather more voices, and then look at how can we actually spark some conversations further as we work towards that development of a policy document, which we know is a kind of multi-year, almost like half a decade kind of approach. And so next slide. So for the first phase of the project, it was really around community engagement. And so we did a participatory design approach that was really looking at gathering the needs and insights, what is currently happening with people in the province. There's lots of literature in this space from 3 different injury groups, and they have done strategy documents in the past. And the Heart and Stroke Foundation really kind of thought, there's so much overlap between the services needed between these injury groups that why don't we actually bring those together and see how we can create a little bit more of an integrated approach rather than doing, a strategy document per group. And so this was the first time that the province has done that. We are really excited to see what are those overlaps and can we actually, create more efficiency by looking at those overlaps and rather than kind of, having 3 separate teams working on this independently. And so how we did that was we did 12 workshops. And so we engaged with people with lived experience. And then actually that same afternoon, we engaged with professionals and we were looking at what was the kind of current state, what were some of their needs, what did they first, some of the questions we asked were, when you first transitioned to rehab and community, what were your recovery needs? Who were the key people in your care network? How have those rules changed? And then we re-engage them a week later online and we're looking at, some of those future questions, like how, if those roles would change, how can you envision that in a new improved system? And it really looked at the future state at that point. And so we had 12 workshops, which was a lot for us. Normally when we do that in person, you'd think like, wow, that would be done over multiple weeks, but kind of shifting it online was an interesting approach, which then led us to have a lot of data to work with. So I'll dive through this a little bit later on, but we did reflexive thematic analysis as a way of summarizing that. And we use Miro as a platform to do that. And really the goal of this first phase was to really look at, what was the boots on the ground feeling of people in the province. And we created a community engagement report, which was 80 pages, filled with illustrations, had lots of quotes that were kind of grounding each of the themes that came out, and there were 5 of them. And then we thought, okay, who's going to read this 80-page report? That's really important, possibly for building the case for the government later on, but we really wanted to make sure it was accessible for a larger group. And so we scaled it down and almost made it into kind of like 10 slides that we shared back with the group. And then, hosted an online event where we went through some of the outcomes of our many months of synthesis together to share that back with the same group who engaged with us the first time, as well as invited a few other people to join as well. And that was our kind of approach of, is what we heard actually, what you said, and making sure that we were constantly kind of engaging back with community before we moved on to the next step. And so the synthesis stage was huge for this, and we'll go through this later. But basically the outcome for this phase was looking at an engagement report that build a stronger case for policy shifts later on. And so next slide, I'll quickly go over what was phase 2. And so phase 2 was really looking at how can we look from the gaps and the needs and those insights and really look at how can we inform that into kind of some policy recommendations. So the steering committee looked at that report and then developed kind of 9 statements around 3 themes of policy that we're looking at: a regional strategy, as well as kind of more community-based services, and how could that be realistically done and implemented province-wide. And so those 9 kind of policy statements, we then wanted to make sure, like, okay, from what we heard from that report, we made these policy statements that are kind of way more condensed. We put out a survey online through Typeform that looked at, asking people to say if they resonated with those statements and to give us a little bit more context to some of those broader ideas. And so on the left here, you'll see an example of kind of this policy recommendation slide or opportunity deck that we made. I'll maybe just read one out quickly, where one of the policy recommendations was, create a province-wide agency responsible for coordinating rehabilitation and recovery services for acute care to the community. And so we had a quote from there that says, I believe having a team effort to aid in recovery from stroke is absolutely essential. I was part of a stroke recovery and community-based group that I found purely by accident. It helped me immensely. Unfortunately, the coordinator quit and the group dissolved. I tried to maintain contact individually, but then COVID happened. And so there's more to that quote, but I won't read it at the moment. But we were looking at, how can we amplify some of these voices and look at how does it relate to the pandemic, current resources that exist, and then, spin it off into a question that could prompt more dialogue. So for this one, it was how might we support individuals' physical, mental livelihood at a community level, and kind of look at, exactly what's happening on the ground and try to respond to that and generate new ideas with people who are change makers, and kind of make sure we're amplifying those voices and really taking what we learned from each of these steps, and then, taking it up to a higher level where we can slowly actually potentially have influence at a policy level. And so the opportunity deck, this is one slide, but there's about, I want to say 40 different cards, and each has a flip side of a question. And on the other side is grounded with at least a few different quotes from the survey. And that's kind of where we've ended off that project at the moment, is handing over this deck and hoping that the steering committee groups, those kind of key organizations in the province, will then take those and have more conversations that are facilitated. And there's a guide in it for that deck for how to prompt more conversations, that not just our design team will have to do that. Actually, each of those team members who are involved throughout this process will then be able to kind of like champion that and have their own conversations and bring that back to the larger group before they move on to the next phase of building that business case. So next slide here. Thanks. And so some key things that we had to consider in terms of pivoting was, January 2022, some restrictions were still up. We were really considering this population health-wise and making sure that we didn't want to expose anyone risk, physically to COVID by gathering in person. And because it's a provincial strategy, flights, travel is actually really, expensive. And so to making sure we were housing people, making sure access from the airport to getting to Emily Carr would have been something to really consider. And so shifting it to online actually meant that, we could engage with people in their own home, and they could just join the same way that everyone else would join, in a box on a screen, and really kind of just be able to engage in a different way. And we found for these populations specifically, they really connected online. It was a moment to kind of meet other people in the community, and independent of us actually facilitating a workshop. And so we noticed even like week to week when they joined back, it was kind of like a moment at the beginning to feel bonded and connected to others, which would have been hard to facilitate in person during January last year. And so that was kind of a key learning for us was, actually we thought online, we weren't quite sure about it in terms of like making and the creativity aspect, but actually the fact of just being able to engage with each other province-wide was a huge benefit and something we would continue to do. The next bit here was around collecting data. So previously, as many designers probably using sticky notes and gathering those, frantically writing them during workshops, we actually did this over Miro. And so behind the scenes, Kaylee Raber, who's the director of the lab, and myself were supporting with note-taking while our students on the projects were facilitating those sessions. And what happened for example, in a breakout room was we had one note taker kind of in the background taking notes. And then we had one facilitator from our design team, as well as one facilitator from the organization who is a kind of context expert. And so what we did was had our laptops, we were taking notes, but we also tried out Otter.ai as a kind of live transcription to the Zoom kind of going on. And so we would like copy from Otter.ai and put it into our Miro board. And it was an interesting balance of trying to practice different note-taking techniques live, which we hadn't necessarily done before. And what was interesting from that is because we were on our laptop, we ended up gathering way more notes probably than we would have gathered if it was in person. And so we ended up having like just under 5,000 individual sticky notes across these 12 workshops. And I don't think we've ever had that much like data to actually then put together. And so that was definitely a huge, I would say, undertaking for our team that we didn't quite anticipate. And I'll talk about it a little bit later, but it ended up being something we would think about in the future around like 12 workshops. That was fabulous. Did we realize actually what the synthesis means once we've done those 12 is a completely different story. So I would say the synthesis actually took about 4 to 6 months to do like honor to that data, which we didn't necessarily anticipate going into the project. And then the other kind of thing here was, I mentioned this before, but the steering committee was so important for this project, and they were kind of like key people from organizations who are leading this work, and constantly engaging back with them around each step was really essential. And we could actually just kind of do our own kind of co-design strategy development on the side, and then have that as a kind of like cycle through for each stage of the project. So that has been really useful to make sure that it's not just a handover at the end of the project, but those key individuals were kind of like informing the key themes and informing the draft development. So they own that information just as much as kind of our team who are like in the weeds on the Miro board looking at the data. And so I'll just go to the next slide here. And so I'll just, now I'll speak to a little bit to our experience and how it relates to transparency. And so for us, transparency was really through engaging with people with lived experience. And that's really core to our values at the Health Design Lab, around grounding everything in the voice of people who would be impacted by whatever outcomes or outputs for a project. And so for us, looking at how do we uplift and amplify those voices was so essential. And, literature was key and a key part of the process as well. But the steering committee had already had lots of those strategy reports, had been engaged for decades in doing that type of work, and recognized in the province it was getting a little bit stuck. And so they wanted to make sure that it was grounded in the voice of people in 2022, in 2023, and really allowing that to kind of guide the entire process, and let literature and kind of key expert voices then be kind of secondary to supplement and support that. And, in terms of transparency and looking at how do you go from engagement to policy, for us, that was really a nice way of like continuously showing that, okay, there are actually people in the province informing each step of this process, so that we can be confident that, where we started on day one and where we are a year and a half later actually does have a clear thread of where that voice follows through. And then next slide. And then transparency and sense making. And so these are just maybe a couple screenshots of our boards. We have, I think, like 6 or 7 Miro boards. And we had 2 student coders who really looked at those 5,000 sticky notes on Miro to kind of do reflexive thematic analysis. And we chose to have 2 coders just to make sure there was a little bit of back and forth and accountability of that process, and key moments where we would come back to the larger team, kind of review at a high level some of the core themes that came out, and then go back to coding that information again. And doing that in stages was really kind of important. And we made sure we copied over board so that we had the raw data and could actually show that process and come back to it in case if we needed to. And one really interesting thing was there was actually moments where we felt like we got stuck, and it was really important to actually get off of Miro. And so that's where we have this kind of image on the side here. That was these sticky notes here in the lab. And we kind of just had our team at the Health Design Lab, pull off some of the key points that were happening in that board and actually just draft them up and talk them through. And so I think we did this about 7 different times where we had the Miro session, we had our session with the in-person notes, then we would go to the steering committee, draft up a version of the report, and cycle through that 7 different times, which is why it took 6 months to do it, to feel where we landed in a really confident space. But I feel like these are these things that people don't talk about sometimes in projects, that it's we have a report, it's 82 pages, look how, publish it online. But actually this process of making sure that we honored the voices and represented it in a way that made sense for all these different organizations and groups, and also didn't lose the thread of the voices of people who engage, was really essential. And so we feel good 6 months later about having a track record or paper trail of how that was, so that if anyone ever asks us, we can be really confident to be yes, we definitely did our best to try to amplify everybody's perspective in the best way. And then just the next slide here was around Yeah, reports sometimes can be complicated and not the most accessible thing. And so we tried to make sure we tried to summarize our findings, in a visual way. And so we had 2 diagrams that kind of basically give a summary of each of those phases at a very high level. So if someone wanted to dig in and learn a little bit more, they could read through the 10 pages further. But if someone really just wanted like, what's the elevator pitch of what your project's about, we really had some of this information shared here. And so knowledge translation, I think, was something key of like, how do we visually design not only the tools that we're using to engage people, but the tools in which we're sharing back information was kind of really essential for us. And next slide. And then, yeah, so re-engagement was just really essential. And so I just put a quick QR code there around the survey that we developed to kind of gather feedback on the initial report. And what we did it as was the first half of the survey was really actually just the report in a kind of like learning module format. So if people didn't want to read the final, long thing, they could actually just click through and get some key insights. And then directly after that, we re-engage people to say, okay, what do you think about these points that we brought up? And do you have anything more to share? And so surveys can sometimes be dry, but for this one, we actually really tried to see like, how can we actually make this as engaging as possible to like do it with care so that people respond with the same level of effort as well. And then the opportunity slide deck, as I mentioned earlier, was kind of a way of keeping that thread all the way through and then amplifying that knowledge back in a way that key kind of stakeholders in the province could then have more conversations around the key topics that came up. Okay, and then just next slide here. Yeah, so just kind of key outcomes. Those were a couple of the reports and the slide decks are kind of key things that came out of this, but I just wanted to highlight that, there's always a thing sometimes at the end, but actually this process and the learning around how do you synthesize information with care? How do you do that in a way that honors the voices? That's actually the meat of the project and some of the key learnings for our teams that will definitely amplify to other initiatives. And then from a people and kind of skills perspectives, we have now a better understanding of the value of virtual engagement and, how it creates access for more people to join. There's a comfort from joining from home, as well as kind of a, ease with re-engagement that can happen. Another thing for our team's capacity was looking at familiarization with facilitation and synthesis in a virtual environment. Being able to create space and how to hold that space is definitely different than it is in person. And so acknowledging that that is actually a skill set that needs to be practiced and developed, I think is really important for people considering doing things online. And then the last thing around kind of process and thinking, we underestimated how long that, sense-making phase of the project took. And so just, the more workshops that you have, especially online, there's like a level of specificity, I think, that starts happening in data gathering and knowing like, how will that actually impact when you're trying to make sense of that information later? And so making sure for a timeline of a project that you're building that space in to kind of not be, it's almost like exponential from the amount of like workshops that you're hosting. And then the last thing here was around collaboration. It's really interesting. Yeah, we feel like we're not limited by geography now. And so that really works well for provincial strategies where it's not just as hyper-local here in Vancouver, but we can reach, not only participants from across the province, but actually work with organizations across the province at that level where, it feels like we're, in the same space. Or 3 years ago, that was something we wouldn't have even considered. So that's definitely a huge push forward and pivot that, allows us to kind of have more impact potentially for, co-design in health in BC. Great, so I think that's all. Thanks everyone. And just my contact info there if you're keen to reach out.
Thanks so much, Nadia. It was great. All right. So I think we're going to wrap up here. I just want to thank Nadia, Joe, Damien, and Katie so much for speaking. Great presentations and great work. Really excellent projects, and it seems like a lot of mentions of the importance of transparency and key voices, engagement in policy and sense making within those projects. So if there's any questions about the webinar, please feel free to contact me. I will put my contact info in the chat. If you'd like to join the conversation or the community of practice for this project, our last slide, here we go, has a QR code to join the COP if you're not already a member. And we've also got a survey if you've been working on healthcare projects during the pandemic and are a designer or are interested in co-design. We've got a survey related to this issue. So yeah, really great talks today. Thanks everyone for coming and for the speakers for speaking. I should mention our next webinar is going to be October 26th from 6 to 8 p.m. Eastern time zone, and it's going to be hosted by the Health Design Studio. Thanks, everyone.
Thank you very much.
Thank you.
Thank you,
Thanks for
Gillian.
joining.
Thank you.